Welcome everyone to one of our BJJ podcasts for the month of November. I'm Andrew Duckworth and a warm welcome back to you all from our team here at the Bone and Joint Journal. As always, we'd like to thank all of you for your continued comments and support, as well as a big thanks to our many authors and colleagues who've taken part. We hope that you're continuing to enjoy our podcasts and all of our knowledge translation work delivered from your team here at the Journal. Our podcasts continue to focus on papers published each month here at the BJJ, as well as our accompanying special edition podcast series. So today I have the pleasure to welcome back my editorial board colleague here at the Journal, Professor Matt Costa from Oxford, to discuss their paper entitled Cost Utility Analysis of Surgical Fixation with Kirschner Wire versus Casting After a Fracture of the Distal Radius, a Health Economic Evaluation of the Draft 2 trial. Welcome back, Matt. It's great to have you with us as always.
Thanks, Andrew.
So, Matt, the aim of this study in particular, the one that's published in the journal, was to compare the cost effectiveness of fixation with K-wires versus a molded cast for adults following a manipulation of a fracture of the distal radius in an operating theatre setting, which is important, as we'll come on to, using data from the Draft 2 trial. So, Matt, maybe as a background and maybe taking a step back, for our listeners, can you give us a brief overview of maybe Draft 1? Briefly, a lot of them will know about it, and then how this sort of led into Draft 2.
Sure. So Draft 1, crikey, it seems like a long time ago now. It started out sort of 13, 14 years ago, but it was a very simple idea to compare locking plate fixation versus wire fixation for patients with a dorsally displaced fracture in whom a closed reduction was achievable. So that's important. It was, if you couldn't reduce the fracture closed, then obviously it wouldn't be appropriate to wire it. So it was for those patients who had a closed reduction that was successful, of course, which was most of them. And much to my surprise, and the surprise of the Hand Society in particular, it turns out that if you can maintain the reduction, then how you hold it there doesn't really matter. So the wires gave very similar clinical outcomes to the plate fixation. But because, interestingly, all of the cost of resource use was linked to the use of the choice of implant, then the wires were much cheaper. And so it was cost effective to use wire fixation. And that led to a change in clinical practice in the UK, quite a marked one, actually, quite interestingly. And also a change in the NICE guidance, so our guidelines on how to manage a broken wrist, which basically said, if you can achieve a closed reduction, then you can use wires to hold it there and reserve plates for those patients who require an open reduction.
Yeah.
So the follow-on from that was, well, if we can achieve a reduction, it doesn't matter which bit of metal we use to hold it there. Do we need a bit of metal at all, or will a molded close contact cast intervention provide similar outcomes? And that was the basis for Draft 2, which compared wire fixation versus a plastic cast, basically a molded cast, for patients where a closed reduction could be achieved.
That's brilliant, Matt. And like I say, I think you always emphasize this when I've heard you talk about it as well, but it's those fractures that you can reduce close. And I think some people get a bit wound up about these things and think that, it's not suitable for all fractures, but that's not actually what it says. It's for those fractures that you can reduce close and hold in that way. Yeah.
Yeah, absolutely. So I still use plenty of plates in my clinical practice, as we all do, but I'm just a bit more selective and reserve those for where the bits of the lunate fossa fragments are facing the wrong way, and I need to open up the front of the wrist. And if I'm there anyway, to put a plate on, that makes a lot of sense. But yeah, so it was reducing the indications for plates, but certainly not saying thread them out.
Absolutely, absolutely. And so if we just briefly, before we go on to this paper, Draft 2 was recently published in the BMJ, and what were the key clinical findings, I suppose, from that?
Yeah, so I guess two really important bits of information, the headlines, if you like, were that if you can hold the reduction in the right place, it doesn't matter how you hold it there. So the patients who had wires versus cast ended up with functional, or had the same very, very similar functional outcomes and quality of life outcomes within the first year. So at each time points in that first year of follow-up. However, 1 in 8 of the patients in the plasticast group lost their reduction in the first couple of weeks afterwards. And everyone clinically will recognize that phenomenon. When the swelling goes down, the cast gets a bit loose and you can lose position. So not a huge surprise, but really important to quantify what proportion of patients ended up with that problem. So 1 in 8 required a surgical intervention, and usually then a fixation, of course, for their fracture. The corollary of that, of course, is that 7 out of 8 didn't need a fracture. And from a patient's perspective, that's not too bad odds to avoid surgery if you can.
Yeah.
But this is where the cost effectiveness comes in, because that degree of nuance is important for the interpretation of the resource use data as well as the clinical outcomes.
No, absolutely. I think that it's nice that we've covered that already, because I think, like you say, when you're interpreting this paper, the cost effectiveness paper, knowing that 1 in 8 number is actually quite important, isn't it? Because it has implications for how the costs and the complications, etc. So if we move on to this study, obviously, as I said, this is an economic valuation based on data collected from draft 2. We know draft 2, a big multi-center UK trial. So Matt, it maybe just as going back again a step, just roughly the inclusion exclusion criteria for the trial. I know they're very clear from the original paper, just so that people know what sort of patients we're talking about here.
Yeah, so we try and keep these as broad as possible. So the inclusion was basically if you were an adult, so anyone over the age of 16 with a dorsally displaced distal radius fracture, and your surgeon, in conjunction with the patient, obviously decided that a manipulation was appropriate, so the fracture was displaced, then you were included in the trial. Patients who were excluded if a closed reduction couldn't be achieved. That was the key criteria. So all of the patients in the study were randomized after they'd had a successful closed reduction of that fracture. A few other exclusion criteria were used rarely. So open fractures, where the soft tissue injury obviously dictates the management much more. Patients who had extensions into the shaft, a different pattern of injury. And the only other serious inclusion criteria, or important inclusion criteria, was that patients who couldn't provide follow-up data were excluded. So patients with cognitive impairments, dementia and so on couldn't take part. But obviously surgical intervention in that group is relatively rare.
And Matt, just before we move on, so and as we've already mentioned, these are patients, like you say, the fracture was reduced, closed, and it was in theatre, and that's the point at which they were randomised. That's correct, isn't it?
Absolutely. So in this study, we learned a bit from the first draft trial. So I think surgeons were understandably cautious about randomising before they did attempted reduction. Yeah. So we wanted them to be able to be confident they'd achieve a reduction before randomising to the 2 interventions. And obviously, if one of the interventions required a surgical implant, wires in this case, that had to be done in the operating theatre environment. So all of the patients were randomised in theatre once the reduction had been achieved. Yeah. Most of them under general anaesthetic, some under regional blocks and so on, but all in an operating theatre environment.
Excellent. Yeah, great. So if we just move on, before we talk about the results, just briefly about the sort of important data that they collected for this type of study. So how was sort of data on resource use collected, and how did you sort of assess and evaluation of costs was done?
Sure, yeah. So there's 2 key elements of the data that inform the cost effectiveness evaluation, obviously the outcomes for the patient and also the resource use. So the resource use that we collect is as broad as possible, but the primary analysis is based on what NICE look for, which is the National Health Service and Personal Social Service perspective. That's what the economists call it. So what does that mean? It's basically what the taxpayer is paying for. So everything in the NHS and everything that's paid for through social services in the community. We then add on to that what it costs the patient, so time off work and so on. So a broader societal perspective, but the primary analysis is based on the NICE recommendation for the perspective that NICE recommends, which is about the NHS and personal social services. Yeah. In terms of how we collect the data, the within hospital data was collected by research nurses in the wards and in theatres and so on. So time in surgery, how many physiotherapist appointments they had, so on. All of that was collected through the research nurses, and then the extra resource use was collected from the patients directly at 3, 6, and 12 months afterwards through a questionnaire where they say, have they required any extra home help? Have they required any other support at home? Have they been off work? And if so, for how long? And all of those data as well.
Yeah, great. And like, as I know we've said before, Matt, and people who've been involved in trials, the health economic data collection is often the vast majority of a booklet, isn't it? Really, in many ways,
it is. It's huge. So just for everyone, so they're aware that we micro cost all of the resource use. So not only do we ask what medication you've had, but it's how many pills and for how long, and then we cost each pill. So it's quite a big burden for the patients to fill us in, and that's important to understand because that affects obviously completion rates and how much missing data we have in there, which I guess we'll talk about, Andrew.
Yeah, absolutely. You've sort of mentioned it already in terms of the importance of the valuation of health outcomes, and obviously we people will have heard of the QALYs and quality of life years again. But could you sort of very, very briefly before we move on, sort of give listeners a background to the sort of the NICE effectiveness cost thresholds and how these were sort of employed within this study itself?
Yeah, so the primary outcome measure for the clinical trial was actually patient-reported wrist evaluation, so pain and function of the wrist. But you can't use that score and compare it across healthcare systems for different conditions. So the way that NICE asked us to collect outcomes from clinical effectiveness, so patient-centered outcomes, is through quality-adjusted life years. And we do that through a general health-related quality of life questionnaire. We used something called the EuroQual 5 dimensions, which is the most commonly used, certainly in Europe and actually increasingly around the world, to collect quality of life data. And it's basically 5 domains of health. So pain, can you look after yourself, daily activity of living, anxiety and depression, and so on. So it's a very broad measurement, and that allows NICE to compare and contrast cost effectiveness across different conditions. So you can cost up someone having a heart attack versus someone having a stroke versus someone having a broken wrist, and compare the effectiveness of different interventions. So that's why we use that particular outcome tool.
Yeah, absolutely. And in terms of the thresholds that NICE often use, that the sort of £20,000 is often the quoted for a quality. Is that right?
Yeah. So the 2 bits of information, then you've got the resource use, so basically what it costs, and then how much benefit in terms of quality adjusted life days you have. And then you can calculate a ratio for each intervention of what it costs per quality gained from that intervention. And the new intervention, if you like, usually more expensive, but not necessarily, is compared to the standard of care. And then the difference in the cost per quality gives you this ratio that allows you to judge cost effectiveness. So economists talk about incremental cost effectiveness ratios. So I probably won't go into any more detail on that.
No.
And then each country, each healthcare system has to decide what it's willing to pay for one quality adjusted life year improvement. And that's where these thresholds come in. And NICE sets this at £20,000 per quality, roughly. And that changes a little bit depending on the economy and so on. Within the study, we did what we call sensitivity analysis, where the primary analysis was based on £20,000 per quality. Is it cost effectiveness at that threshold? But we also did a subsequent analysis using £30,000 or £15,000, so a higher or lower value. And that's hopefully to make it a bit more applicable to other healthcare systems that might pay a bit more or indeed a bit less for an improvement in quality adjusted life.
Absolutely. Yeah, that's brilliant, Matt. And I think that gives the listeners a really good overview of how, sort of breaking down those nuances and those terms that we use. So moving on to the results of the paper, just very briefly for our listeners, there were 500 patients randomly allocated in the trial, 255 received a cast, 245 K-wires. After manipulation of their fracture, the mean age, in the 2 groups was 59 years and 61 years respectively, and the majority of trial participants were female and had an extra-articular fracture, very consistent with standard sort of a distal radius fracture epidemiological data. So first, Matt, we've already mentioned it briefly, but before we get onto sort of the nuances of the results, you mentioned the word like completion rate. What was the completion rate of the health outcomes and resource use data for this study, and how did you sort of deal maybe with missing data?
Sure. So there's always, because of the detail we're asking patients to complete, there's always some missing data. Now, quite remarkably, 58%, so over half of all the patients gave us a complete data set. So every single question was answered, which is quite amazing considering how much detail we're asking here. So that's a testament to an awful lot of work from the trial team to chase patients up and ask them to fill out these questionnaires. The way we deal with missing data, though, is with the primary analysis is using imputation, which I won't go into detail on that, mostly because I'll get myself in trouble with the economists. But it basically, you take repeated samples from the data you have got and run those samples as though they're independent trials. And you do that thousands of times. And that gives you an overall estimate to how much effect missing data would have on the actual overall outcome. I've not explained that terribly well, but it's probably the best I can do there. So that's how we deal with missing data. It's built into the primary analysis. And you can do that with clinical outcomes as well, using the same bootstrapping techniques, but actually it's very commonly, it's the usual way of doing things for a health economic analysis, certainly in the UK.
Yeah, no, absolutely. And like for many of our listeners, like you've already said, almost 60% of patients having every field completed is, I know it's remarkable really in terms of the amount of data they've got to fill in. And that's actually, like you say, that's every time point, every data point. Whereas, you might have some at 3 months, some at 6 months and variable, return rates at that time, won't you?
Absolutely. So yeah, some patients reply at 3 months, but not at 6, and then reply again at 12. So the data is monotonic, I think is the term that the economists use. But yeah, so if any patient gives us any data, we always include it in the analysis, basically.
Absolutely. So if we go on to sort of the key findings of the results briefly, so what did you find, the key things in terms of the healthcare and the personal service use rates and costs?
Sure. Well, as you probably expect, most of the resource use is driven by the initial hospital episode.
Mm-hmm.
So what it costs to actually have the surgery and then have the immediate care in the hospital. So whether it's day case or overnight stays. Follow-up was also quite a strong resource driver. So the amount of physiotherapy people had, the number of outpatient appointments they had, and so on. And then a really important item was the secondary surgery. So we micro-costed up anyone that had to have a further operation further down the line. And what it basically shows is that it's slightly less resource use, even with 1 in 8 patients requiring a second operation. Putting a cast on is slightly cheaper than it is to actually treat people with wires, but only a tiny amount, really.
Yeah.
On the quality of life side, there was no difference essentially at any time point. So really nothing at all there. So you've got the same qualities and a marginally cheaper intervention overall for the NHS and social care services. The differences out of the hospital in terms of social care use and time off work and the societal perspective were minimal. There was very little difference there. So the small cost differences were driven by the actual hospital care, mostly the first visit, so when they had the surgery.
When they had the surgery, absolutely. And if you then take that forward in terms of the health utilities and cost effectiveness, what did that show?
So the ratio really shows that, so at a willingness to pay of £20,000 per quality adjusted life year, so a nice threshold, it's unlikely that wire fixation is cost effective. There's only a 24% probability that it would be cost effective. So that's the headline figure, is that it's unlikely that wires are a cost effective intervention for this particular problem, but there's some nuance associated with that.
Yeah, absolutely. No, we'll come on to them. So I think we'll come to them now, actually, because I think that's a nice way to lead into it. So, if we sort of draw that all together, I think the strengths of the study are clear: a huge, large UK-based multi-center trauma trial, excellent design and execution as always, and a comprehensive collection assessment of resource use and costs associated with it. Very nicely done, and obviously very clearly robust analysis, which you can see from the study itself and the paper. And like you say, within this sort of within trial economic evaluation of draft 2, it indicates that, like you say, manipulation and KY fixation is it's slightly more costly and doesn't really result in a significant increase in the qualities in comparison to a molded cast, and therefore it's unlikely but to be of benefit. But I think there's a few nuances to it, and what I suppose what those nuances you'd want to highlight to the listeners, Matt, in terms of some of the things we've mentioned already.
So with any health economic evaluation, you write an evaluation analysis plan. So the same way that with any trial, we write a statistical analysis plan to say up front what we're going to do with these data and how we're going to adjust it, so everyone knows that what we're planning to do and make sure we stick with the plan. And we do exactly the same thing with an economic analysis. We say what analysis we're going to do, and then we work from that rate. So essentially, we're playing a very straight bat. So what's reported in the paper is the absolute, what we said we do, and these are the results. So it's not likely to be cost effective to use wires in this situation, but the absolute cost difference is marginal. It's about £13, I think, per patient. So if you take the patient perspective, if I'm going to an operating theatre and I need to have something done, they will accept that if that's the recommendation and they agree with that. If they've got to go back again, though, that's quite a big deal. So it might be marginally cheaper for the NHS. But if I'm a patient and I'm in an operating theatre environment, and for the sake of £13, you can reduce my risk of coming back, well, frankly, I probably want the wires put in. And so for me, the outcome of this was that I would probably, if I have to be in the operating theatre and I'm doing a close reduction and I've achieved that, then I'm going to put the wires in to save 1 in 8 of my patients having to come back again. So there's the headline result of the trial and then what that means in clinical practice. The really important bit of information, though, is if you can hold them with a cast, they will get the same functional outcome. So then the question is, if we did the cast outside of an operating theatre environment, then that, of course, will be hugely cost effective because you've reduced the cost dramatically if you do it in the plaster room in outpatient department. But that wasn't the intervention in the study. So we're extrapolating from there, and everyone, all the listeners have got to decide whether they think that's a reasonable extrapolation of the study, but it's certainly changed. That's where my clinical practice has gone, and my colleagues in Oxford, and I think lots of the other hand centres are moving in that direction as well, of attempting to close reduction and close contact casts outside of the operating theatre. And then if you're going to theatre, then it's probably better for the patient overall to have some sort of fixation of the wrist.
And I think that's really interesting, Matt, and a really nice way to put it. Like you say, it's sort of like you can always look at just the headline result of the trial, but actually there's how you adapt that to our day-to-day clinical practices. Do you have a feel of what the patients would want, in terms of, because I mean, I think you could get a variety of responses there in terms of some would say, I want it reduced, but I don't want any wires in it, or vice versa. I just want the definitive treatment now and I don't want to have to come back. So
no, absolutely. But it's really interesting, and we've done a lot of patient experience work across loads of trials for quite a long time now. And one of the very consistent messages, whether it's a broken leg or a hip or a wrist, is that the only people that think surgery a good idea is surgeons. So patients generally want to avoid going to an operating theatre. It was interesting, some of my colleague Dan Perry's work with the children is that the parents on behalf of their children, that's an even bigger issue, because handing your child over in an anaesthetic room and then being escorted out of the room and leaving them there is a huge issue for the patient. So avoiding surgery is massive. So they will accept all kinds of things you would think, empirically, they wouldn't want the child to have a wonky looking wrist.
Yeah.
But if it avoids an operation and there's a hope they will remodel, the patients is happy to take part. So it's the same with the broken wrist, that patients, particularly the older patients who are the predominant, patient group for distal radius fractures, we're not afraid of surgery. So they said if it needs doing, it needs doing, that's fine. But if we can avoid going to an operating theatre, then that's what we want. That's empirically what we want. And that was a really clear message when we asked the patients about their interpretation of the trial. And so that appears in the patient-facing materials quite clearly, that they want to avoid surgery if they can.
Yeah, absolutely. I think that's really interesting. And just a final few questions in terms of, we've talked about the strengths. Are there any sort of limitations to the study or anything you would have done differently in hindsight, maybe?
Yeah, so we made a choice up front to do the randomization in theatre after the reduction was achieved, and that committed us to being in the operating theatre. So I guess that's the key thing, really. Now, the win from that was that we include the surgeons were already happy about the reduction before they were randomized. So that's clear. The downside is, of course, that you drive up the cost by just being in an operating theatre.
Yeah.
So we have and ahed about whether we need to repeat the study, looking at manipulation and casting in the fracture clinic to see whether that's actually gives you equal result. The difficulty is that since we've started doing that in Oxford, and I know you guys have in Edinburgh as well, and lots of other centres, using finger traps and having a bit of patience and getting the plaster techs to put a cast on, most patients don't even require analgesia, never mind nerve blocks or anaesthetics and things. And so I'm struggling now a little bit to know whether ethically I would be able to randomise patients to go into an operating theatre versus having that manipulation done in the plaster room. And we're not talking about hematoma blocks in ED, which I think, frankly, is torture, but it's still done a lot, I know, but it's really not a pleasant thing to witness, never mind to do. This is a controlled environment with people who do it every day, and I think that's the way forward. So, I mean, we've got a protocol written for that trial, actually, to look at doing it in the operating theatre versus outside, but whether we can ever do that, whether the community thinks that's acceptable, I'm not sure. We'll have to discuss that over the coming months when the trials really settle down and people have digested it.
Absolutely. I suppose that would be the trilogy, though, wouldn't it? That would be draft 3 potentially.
Oh, don't worry, we've got draft 3. That's another one. In fact, draft 3 is just about to start. This is for the patients who haven't needed a manipulation. So if the patients with undisplaced, someone with displaced fractures, we're going to randomise them to a cast versus a removable splint, and then discharge the patients in a removable splint to check they're okay. So it's a non-inferiority trial. Coming to a hospital near you very soon. So
absolutely.
That'll be fascinating, because if one of the real other things we've learned a lot from the patient feedback, and particularly during the pandemic, was they don't want to be in hospital unless they absolutely have to be. So a pathway of care that allows them to manage themselves at home, remove their own splint, is something they're very keen on, but only if it's safe, and that's what we need to establish.
Absolutely, but I think you're right. I think actually, and I think empowering the patients to lead their care is not a bad thing in many ways. I think some people do need our help and intervention, but actually, I think we've assumed for a long time they do always need to come back to us, and that's just not necessarily the case. And it's just inconvenient for them, and it's more for our benefit maybe than theirs sometimes. But no, well, I think Matt, that's great. I'm afraid that's all we have time for today. But so thank you so much for joining us as always, and congratulations on another outstanding study that's again further added to the literature in this area. And it was always great to have you with us.
Thanks, Andrew.
And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through social media alike. Feel free to tweet or post about anything we've discussed here today. And thanks again for joining us. Take care, everyone.